I'm going to cover the concept of standard treatment workflows in ophthalmology. This has been initiated by the ICMR, WHO, and the National Health Authority. Why do we need standard treatment workflows? Basically, in health systems and public health, there's new scientific evidence and rising healthcare costs. So, healthcare providers are not able to keep pace, particularly within the public health system, and there are also bulky, voluminous treatment guidelines. Of course, these are guidelines. They have to be taken in that spirit because when you're handling a patient, there's a lot of individuality in what the physician and the patient situation demands. So they are guidelines and they're not hard and fast rules. Of course, there's a very high doctor-patient ratio, and there's also a lot of pressure on being up with the current protocols. Physicians require a simplified, updated approach and a guideline, and also now there are a lot of non-physicians who are also engaged in the healthcare management systems, as I will explain later on. So it's not that they're going to provide the treatment, but they have kind of a checklist by which they can reconfirm with the physician or the organization about any queries. So standard treatment workflows was a kind of a one-pager concise document which was designed to be utilized at various systems within the healthcare delivery system in our country from primary to tertiary care level, and they've been made available by Government of India to be adopted and followed by all providers. So the goal was to empower primary, secondary, and tertiary care physicians and surgeons towards the overall goal of universal health coverage with disease management protocols. And the objective was to formulate generally universally accepted clinical decision making workflows based on best evidence available. And there was also a side benefit that with the rolling out of the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, that is the sort of a government health insurance system, there was a requirement that there are certain sort of levels which could be considered for considering what should be the treatment that should be authorized or provided. And allowed for, accounted for. Of course, there are many states who have their own individual insurance systems, and there are individual insurance packages, and it's not necessary that they all be equal because in different parts of the country and different requirements, there would be different expenses. So what was the process followed? Initially, it was decided that this was across disciplines, and within each discipline, there was a discussion as to what were the doable disorders and which could be done within a particular time frame. Then there was a group of experts who were put together from different black backgrounds and a review of available current best practices. Looking out of that, what were the evidence available and how could that be modified depending upon the local scenario, then discussion and pre-finalization of the content, which was then conceptualized and went through different iterations of the model because it had to be simple, it had to be as clear as possible, and it all had to be concisely put onto one page, and then it was made available after the printing and dissemination. So generally, the experts were from the All India Institute of Medical Sciences, PGI, MER, Chandigarh, government medical colleges. It also included state and district level program officers, the WHO, private healthcare providers who are also important stakeholders, members of professional associations, super specialty private hospitals, and primary healthcare physicians, trying to make sure that you included the whole gamut of healthcare delivery models available in the country. And then there was a structure, the structural framework was an advisory committee, and then there was under that an STW team, and then specialty wise subcommittees, and then an editorial board, and then it turned out into a form of a book, a mobile app, and a web portal. Now, coming to ophthalmology, initially there was ophthalmology is a huge subject, very vast into itself, and taking into view the data about the important causes of blindness in our country, and also the largest requirement for healthcare service delivery according to what were the requests coming from across the country, we decided on 3 disorders: cataract, glaucoma, and diabetic retinopathy. So for cataract, there was a simplified thing of symptoms, signs, what should be the generalized expected systemic assessment as a baseline. Then an ophthalmic examination, again primary, secondary and tertiary level, preliminary examination, then the essential examination and desirable. Now please remember, this is at different levels. It's not that in at a like a basic level, and then you will refer the patient to the higher level. So this was how it was divided, and largely this was at the primary healthcare level, that it will be the initial screening. Idea being that any patient with these criteria would then be referred to the higher level for the for treatment. So there were the essential. Then once you go to the higher level and cataract is confirmed to be present, which is requiring surgery, there were certain essential investigations, certain desirable investigations. Here, for example, there could be a clinical assessment of a blocked nasolacrimal duct, and then there were optional investigations. Then the indications for surgery, and then proceed for surgery as indicated. And if cataract was found to be absent, the idea was to look for other causes for impaired vision and refer as necessary. And then the cataract with comorbidities and with systemic comorbidities, it was again subdivided as to what were the important associated disorders, and that they would be taken care with the help of the associated medical specialist. And then there was also a protocol for management and follow-up, fitness for surgery, and the quality assessment parameters also, so that there could be a monitoring whether the general level of healthcare delivery at various levels is acceptable according to the norms, and post-op care. So this is all in one page. Here I split it up into three for the convenience, but otherwise all in one page, and you can just go down the list and apply. Coming to diabetic retinopathy, then again there were key points. What should be the preliminary screening, what should be taken in the history, what should be done in the examination, and then they were given standard charts as a kind of sort of a checklist to compare. I'll just take another minute. And then there was a classification, and then again indications for urgent referral. And then again guidelines for management. I'll just take a minute. And then we have glaucoma. Glaucoma was a third disorder. Again, certain key points were identified, then the history, the signs and examination, and what should be done in the OPD, what should be considered as the indications for referral, and the suggested management protocol based on the intraocular pressure, and then what is the management at every level, primary, district, as well as the tertiary, and then the red flags were put for urgent referral. So this is how we have these three disorders. So they're available, as I said, in a book form and an app form, as well as on at the website. And this is the mobile app that could be used, which could be downloaded. Then it was released. This was a central release, and I'd like to acknowledge Dr. Ashu Grover from the ICMR, who has played a key role in coordinating all these activities and making sure that they came out to be at a suitable level. And for future, one could have a discussion as to what additional. We were very keen to include corneal ulcers and trauma, as well as pediatric eye diseases, and that perhaps when they come up with volume 4, one could add these disorders as well. But at the moment, it was going by the large burden of disease and depending upon the healthcare delivery pattern that we have. With that, I'll stop here. I'm happy to take any questions.
Thank.
No longer. No. Clinically, you can easily rule out an infected lacrimal sac, so it's not essential. By pressure on the sac, absolutely. Yeah.
Okay. Oh, I was about to ask, that was one. Second, you have mentioned that B-scan is advisable for total cataract patients. So it's not must.
It depends upon the situation where you are, because B-scan is, if the total cataract, depending upon how much in the periphery you are, that is why it was written in a district hospital, for example, with guarded prognosis, you can go ahead. So that is how it is, keeping that in view.
Okay, thank you. Any other questions? Thank you, ma'am.
Okay, thank you. Thank you so much. Yes, sir. Yes. No, No, see, it depends upon where you are. See, this is the healthcare delivery system. So obviously, if you are in a setup where it's available, there will definitely be a legal implication. But this is a guideline right in the periphery, so that people over there don't, have to suddenly start purchasing a B scan if it's not available. Definitely, if it's that is why it's a guideline and a workflow. And basically, if you have a total cataract, you would like to do a B scan to know what is behind, to plan accordingly. But if it's in the periphery, then it may not be possible. Then you have to do guarded prognosis depending upon the situation. So that is the difference between this kind of a universal guideline which is provided very, very remote areas. Sometimes it is just not possible. And it may be going in for phacomorphic. You leave that patient there, he may go into phacomorphic glaucoma or some other complication. So in those situations, explaining the status, it can be done. You have sometimes very elderly people who are very far off, then you may have to do it with guarded prognosis. But certainly, if you are in a setup where you're in a metro, definitely you would have to do a B scan, and you would like to, and it's not an issue for you because you have it. The situation is when you don't have it. Yes. So, yes. Yes, you can. You can, because this is a help for you, and you can check the digital pressure. If the pressure is low, you may suspect a retinal detachment, and you may have a vitreous hemorrhage. So, with the explained consent that there's a total cataract, you can look at the pupillary reactions, and you can say that these are the things we cannot rule out. We'll go ahead for the surgery. If anything comes after that, we'll refer. And if it's absolutely fine, then patient is happy and you're happy.
So it's like doing just a good documentation of what you are doing and what you have explained to the patient. Consent form.
Yes, yes, definitely. But yes, absolutely. You should have a written consent that in view of the extensive cataract, that's difficult to predict. So, so therefore, it is guarded prognosis, under guarded visual prognosis.
Thank you.
Thank you. And you can also explain that if anything happens, it's not necessarily due to the surgery, it could have been pre-existing. That's very important to explain. Yeah. Thank you.